Okay, hello everyone. So today we are going to discuss about the brachial plexus injury. Okay, so before going to the brachial plexus injury, let's see the introduction to some nerves, right? The number of nerves in our body. Okay, so we have the 31 pairs of spinal nerves, and we have the 12 pairs of cranial nerves, because brachial plexus is a kind of the spinal nerves. That's why we just want to see this one. So these are the number of nerves in our body, and let's see here how is the spinal cord moving. The spinal cord is moving from this foramen, you can see here, right? So this is called the vertebral foramen here, and then the spinal nerves exit from this foramen here on both sides. Okay, so this is called the intervertebral foramen. So this is my spinal nerve which exit from the intervertebral foramen. Okay, so let's see the distribution of the spinal nerves. 31 pairs of spinal nerves we have right now, we said, right? So what are these, the 31 pairs of spinal nerves? So let's see here. This is our brain and our spinal cord. Yes, so we have here the 12 pairs of cranial nerves, and here we have this one, what, 31 pairs of spinal nerves, right? So how are these nerves distributed? Let's see the distribution of these nerves. These nerves are distributed, we will talk about the spinal nerves. How are these distributed? The 31 pairs of spinal nerves, these are distributed according to the vertebral bodies, right? So let's see here. So I consider these vertebra as the thoracic T1, and then this is my T2, this is my T3, T4, T5, and then so on, right? So if you have the spinal cord like this, our spinal nerves, they exit this way from here. Okay, so these are my vertebral bodies, this is my spinal nerves. So what do we see here? These are the, if this is my T1 vertebra, this is my T1 spinal nerve, T2, T3, T4, T5. So what do we see here? The thing is that the spinal nerves exit below the respective vertebral body. This is a rule. Okay, so this is a question we have. Similarly, there are some exceptions over here. So what is that exception? That exception is in the cervical vertebra. Let's see, this is my cervical vertebra, 1 2 3 4 5 6 7, right? So this is my C1 and this is my C7. So let's say C2, C3, C4, C5, and C6. Okay, so in the cervical vertebra, how are my spinal nerves? They exit. Look at here the difference. This is my spinal nerve, the cervical nerve, they're exiting out this way, this way, this way, this way, and here this way as well. So what do we understand here? The each cervical nerve, so let's say this is my C1. If this is my C1, this is my C1 spinal nerve, this is C2, C3, C4, C5, C6, C7. That means this is my C7 vertebra and this is my C7 nerve. This is my C6 vertebra and this is my C6 nerve. This is my C5 vertebra and this is my C5 nerve. So what is the difference between this one and this one? Here let's see, each nerve exit below the vertebral body, the respective vertebral body. T1 vertebra is this one, T1 nerve is below the T1 vertebra. But here C1 vertebra is this one, but this above this one is my C1 nerve. That's why. So in the cervical section of the spinal cord, what is the difference here between this and this? Here we have the cervical spinal nerves exit above the respective vertebral body, right? So this is the difference. Here below the vertebral body, here we have above the vertebral. Another difference is that in the C7, look at here, C7 has one nerve here, one nerve here. That means C7 has above the vertebra also, below the vertebra also, right? So that we have in the C7, it has above also, it has below also, right? So this is my C7 vertebra, and this is above is my C7 spinal nerve, and below is my C8 spinal nerve. So this is also the unique feature. This is also our question, right? So this is the distribution of our nerves in the spinal cord, right? So we understand. And from where they exit from this one. This is our intervertebral foramen. Spinal cord is within the vertebral foramen. What is this one? Vertebral foramen. And the spinal cord exit through this one is my intervertebral foramen. Okay, so this is the introduction of our spinal cord and then the cranial nerves. And then let's see here, how does the spinal nerves forms? The spinal nerves are formed like this. Let's make the spinal cord picture here very quickly. So this is the segment of my spinal cord, and in this spinal cord we have, this is the H-shaped gray matter here, right? And outside we have a white matter. So this is my central canal. So let's see our the spinal cord segment here. So what is this one? This side is my ventral horn. I'm talking about this gray matter. Okay, so this is my gray matter, the H-shaped gray matter here, and outside is my white matter. So this is my white matter, this is my gray matter. Okay, so in the gray matter, this is my ventral horn, this is my ventral horn, and these two are my dorsal horn of the gray matter in the spinal cord. And from here, what happens? How does the spinal nerve exit? From the dorsal horn I exit like this, and from the ventral horn I exit like this, and as I exit over here, terminates over here like this, and then they will go and meet together here. Okay, as they meet over here like this, and after meeting they will move one on this side, one on this side, one on this side, and one on this side, this way. Okay, so what are these things? Let's see. This is my ventral root, this is my dorsal root, this is my dorsal root ganglion, this is my spinal nerve. Once it forms the spinal nerve, it divides into, this is my dorsal ramus, this is my ventral ramus, this is my gray ramus, and this is my white ramus. Okay, so dorsal ramus, it is supplying my back of the body, that means dorsal body surface. This is supplying my front of the body, that means my ventral body surface. Okay, and this white and gray ramus, they are going to my sympathetic, like this. We have the sympathetic chain ganglion over here, right? So these are my sympathetic chain ganglion, sympathetic chain ganglion. These are my paravertebral sympathetic chain ganglion. They enter into this, right? So these sympathetic and parasympathetic, we will talk over here a little bit here. So what are those? The dorsal horn and ventral horn is responsible for. This is my dorsal horn. This dorsal horn is responsible for my sensory root. Ventral horn is responsible for my motor root, and this my lateral horn, it is responsible for my autonomic nervous system. Okay, so this is how we distribute. And then let's talk something about the autonomic nervous system here. Autonomic nervous system, we have two branches. One, we have the sympathetic nervous system. Another one we have is the parasympathetic nervous system. Okay, so in this sympathetic nervous system is, we call this as the thoracolumbar outflow. Thoracolumbar outflow means starting from T1 to L2. This makes my what? The sympathetic outflow, and these nerves which exit from the lateral horn of the this lateral horn of my gray matter of the spinal cord from T1 to L2, they enter into this sympathetic chain ganglion, and then this supplies the sympathetic nervous system, the sympathetic activities of our body. And parasympathetic nervous system, we call this as the craniosacral outflow. Cranium means it has some nerve from the brain and some nerve from the sacrum. So the nerve coming from the cranium, that means the brain, these are the cranial nerve 3, 7, 9 and 10, plus sacral nerve S2 to S4, that is S2, S3, S4. So this is cranium and this is sacrum. They form the parasympathetic supply of our body, right? So this is how the nerves are distributed. So we just discussed over here the dorsal root ganglion, the what is this one, dorsal root, the ventral root, the spinal nerve, the gray ramus, white ramus, the dorsal ramus, the ventral ramus, right? So these all things we can see here in this picture. This is, we have a ready-made picture over here. So in this picture what do we see is this is the half of our spinal cord we make, right? And in this half spinal cord, this is white matter and this is our gray matter. In this gray matter, this is my dorsal horn and this is my ventral horn, right? So from the ventral horn we have one root going over here. From the dorsal horn we have a root going over here. This is my dorsal root, this is my ventral root. Okay, so this ventral root and this dorsal root is my sensory, dorsal root is my what? This is sensory, ventral root is my what? Motor, right? So finally the dorsal root, it goes and enters into the dorsal root ganglion, and then they come and combine together here, they form the spinal nerve. Spinal nerve divides into one. This is my dorsal ramus, this is my ventral ramus, and this is my white ramus, this is my gray ramus, right? So I say dorsal ramus, it is supplying what? The dorsal ramus is supplying my dorsal body surface. Ventral ramus is supplying my ventral body surface, right? So this is how they are going. And then white ramus and gray ramus, they are going into what? Sympathetic ganglion, right? Sympathetic ganglion. So let's see, the sympathetic ganglion are over here, we can see in this picture, right? So in this picture we can see over here, can you see this one nerve, this one, another nerve, and here you can see two nerves, yes or no? So this one is our ventral ramus, sorry, dorsal ramus, ventral ramus, and these are our white and gray ramus. They're going into our sympathetic ganglion. So these are our paravertebral sympathetic ganglion. All right, so this is how they are distributed, and we can see this image over here as well. So in this image what do we see? Spinal cord over here, dorsal root, ventral root, dorsal root ganglion combined together, spinal nerve, this is ventral ramus, this is dorsal ramus, and here we have two, right? So these are white and gray ramus. So these white and gray ramus are forming like this. We have the sympathetic ganglion, right? So these are the distributions of the spinal nerves and then the ramus. And why we discuss this much is that our the brachial plexus is formed, our brachial plexus is formed by the root C5 to T1 if it is the normal, and above C5 is the prefix and below T1 is the postfix. And in this distribution we can see over here, as we say, the brachial plexus is formed by the ventral rami of C5 to T1. So that means the ventral rami, to understand this ventral rami, we just see these distributions right now here. These ventral rami from C5 to T1, they are forming our what? The brachial plexus, right? So we're going to discuss about the brachial plexus injury. So to discuss about the brachial plexus injury, let's discuss here. So this brachial plexus injury we divide into two groups, this one part and this one part. Okay, so here in this region we have this bone, right? So this bone is my what? Clavicle. What is this one? Clavicle. So this part is above the clavicle, and here this part is below the clavicle. So we say this is infraclavicular. What is this one? This is, let's make this color, this is my infraclavicular, and this is my supraclavicular, and this is my clavicle, right? So we can divide this brachial plexus injury into these two types. One is supraclavicular injury and another one is what? Infraclavicular injury. So in the supraclavicular injury also we can divide this into two types, that is root and trunk. And infraclavicular injury also we can divide into two types, that is cord and branches injury. Is that okay? So supraclavicular injury, we have the roots injury and then the trunk injury, right? The root injury we further divide into two types. For example, like we can divide this root as this line. If we divide this line and we imagine here we have the dorsal root ganglia. What do we have here? The dorsal root ganglia present over here. If you remember the dorsal root ganglia, right? So we can divide this into two types again. This is the root. So these root divisions we can say as the pre-ganglionic and post-ganglionic. That is pre-ganglionic and this is my post-ganglionic. So pre-ganglionic means before or above the dorsal root ganglia. Post-ganglionic means that below the dorsal root ganglia injury, right? This we are talking about the site of injury. And then we'll go to the trunk. In the trunk we have here superior trunk injury or inferior trunk injury, okay? So superior trunk injury is called the Oph's palsy and inferior trunk injury is called the Klumpke's palsy, okay? So see, here is the trick. E comes first then K. That's why we can say this is the Oph's palsy. Oph's palsy is above. E is above the K. That's why Oph's palsy is the superior trunk or the upper trunk, and then the Klumpke's palsy is the inferior trunk injury, okay? And we go to the infraclavicular injury. In the infraclavicular injury, we say the cord injury or the branches injury. And in this cord and branches injury also, we will divide them into different types, okay? So we will discuss this in details, right? So in this cords and branches injury, we will divide this cords and branches injury into the very high lesion, and then the low lesion, okay? That means according to the location where we are injuring this brachial plexus, okay? So these are the brachial plexus injury. So now let's go to the classification. So we can see here in this picture, what do we see is that this is our clavicle and above the clavicle is our supraclavicular. Below the clavicle is our infraclavicular, and in this infraclavicular and supraclavicular we have the further type, right? Supraclavicular, we have two things over here. These are my trunks, these are my roots and trunk. And infraclavicular, these are my cords and these are my branches. That's why we say infraclavicular I have two locations of injury, that is cords injury or branches injury. Supraclavicular I have the root injury or the trunk injury, right? So let's say the location of the injury. What do we understand here? The supraclavicular injury, right? So the supraclavicular injury, we have what? This is above the clavicle, right? So this is my above the clavicle. This is the location. And what are those? The components? Maybe root or maybe the trunk, yes? And if it is the root, in the root we just divide, like it may be what is this one? The pre-ganglionic or post-ganglionic, right? Pre-ganglionic means what? Pre-ganglionic means above the DRG. Post-ganglionic means below the DRG, right? So these are the question in the exam, okay? So this is my question, this is my question, all right? And trunk, in the trunk also we divide them into two types, right? So these two types are, one we said the upper trunk, another one we say the lower trunk, right? So this is my upper trunk, this is my lower trunk. If upper trunk injury, that is called what? Oph's palsy. If it is lower trunk, we say this is what? Klumpke's palsy. Is that okay? So these two types we just discussed, right? Now let's go to the infraclaviculars. In the infraclavicular injury, Infraclavicular, we also said two types here, yes or no? Two locations here. One is the cord, another one is what? The branches. So let's say this is my cord, or this is my what? Branches, right? So it may be in the cord or it may be in the branches, the injury. These are the locations which is discussed. According to the locations, we classify the injury of the brachial plexus. Here, please remember this for the question, this for the questions, okay? This is question, this is question. Is that clear? Now, let's go forward with the most common injuries. So, what are the most common cause of the injuries? Like the most common injuries first, and then we go to the causes or etiology. So, supraclavicular injuries, we divide the supraclavicular injuries into the three forms. It may involve the root, right? If it involve the root, in this root, it may involve the complete root. Complete root means C5 to T1, or it may involve the certain roots only, certain roots. In the certain roots, it may involve the long thoracic nerve, or it may involve the dorsal scapular nerve. If you remember, these are the branches of the root that we discussed as DSLR, right? So they may involve long thoracic nerve, or they may involve the dorsal scapular nerve. So among this is most common among the root involvement. So complete root involvement is the most common type, and this is most commonly due to the mechanical injury, that is mechanical injury. Is that okay? So these are the roots. And another one is the trunk. They may involve the trunk, like we said the upper trunk, we said the lower trunk, right? So they may involve the upper trunk or maybe the lower trunk. If it is upper trunk, this is called what? Ops palsy, right? And remember, Ops palsy is the most common brachial plexus injury. This is the question in the exam. This is also the question, okay? Most common brachial plexus injury is the upper trunk injury, that is Ops palsy. It involves the root values C5 and C6, right? And lower trunk injury, that is called what? Klumpke's palsy, right? So this is our lower trunk, and this is involvement of which root values? This is also the question, C8 and T1. This is also our question in the exam. And then let's go to the infraclavicular most common injury. So in the infraclavicular, as we said, infraclavicular, we have the three different locations of the injury. So these three different locations are maybe very high lesion, or maybe high lesion, or maybe low lesion, okay? If we say very high, if it is very high, then the location of injury is axilla. And if we say high means it is in the arm. If we say low lesion means it is around the elbow or below that, right? So these are the sites of the injuries. And these infraclavicular injuries, it involves the two things, as we said, yes or no? One is the cord and another one is the branches, right? So that's why the most common branch of brachial plexus injury, that is our radial nerve. So this is also our question. Is that okay? So let's see here why we give the heading here, the most common injury. That means let's see here, most common here, and we see here the the most common. Here we see the most common, right? So that's why these are the questions as we discuss here. This supraclavicular injury and infraclavicular injuries. Now let's go to the etiology. What is the cause of this the injury of the brachial plexus? So in the etiology, we divide this etiology into four types. One, traumatic, obstetric, Burner and Stinger's, Parsonage-Turner syndrome, right? So let's see traumatic injury. The traumatic injury, among all the causes, traumatic injury is the most common cause of most common cause of brachial plexus injury. Okay, this is the most common cause of brachial plexus injury. This is our question. And among these traumatic injury also, the most common one is the high velocity road traffic accident, we can say easily, right? So this is our road traffic accident. Among the traumatic, this is the most common cause. So this is another question here, right? And then another traumatic injury is the caudal force of the shoulder, right? That means the CAUDL, caudal displacement of shoulder. This caudal displacement of shoulder means we can see here, right? So this is the caudal displacement of shoulder, or this is also called the hyperextension of the neck. You can see here, this is our neck hyperextension. So this is neck caudal displacement or neck hyperextension, right? So if it happens, so look at here, neck hyperextension in this picture, or in this picture the force, this is our the delivery, right? Anyway, the obstetric delivery. So if we have the neck hyperextension or the caudal displacement of the shoulder, yes, it has the chances of causing the upper trunk injury. That means it produces what? Ops palsy. Remember, this is also the question. Similarly, another cause is what? The another cause we can see over here. What is going on in this picture and this picture? See, we are pulling by the arm. That means our arm is hyperabducted, right? So arm hyperabduction. By doing this one, it can cause easily the injury to our lower trunk. If the lower trunk is injured, what is the problem called? This is called Klumpke's palsy. Okay, so Klumpke's palsy. Look at here. This is this is causing Klumpke's palsy, and this is causing what? The Ops palsy. So please remember. So the picture, the position over here. Okay. So in these two conditions, right? So and then these two conditions is causing the Klumpke's palsy. So please remember the picture. They will give you the pictorial questions. And then, so these are the traumatic injuries we said. And then let's go to the obstetric injuries. In the obstetric injuries, just you can see one picture here, another picture over here. So this picture is what? This is our breech presentation. Breech, or let's say breech delivery. In the breech delivery, what is the presented part? This is the arm presented part, or the hand, right? Hand presentation. Yes or no? So this hand presentation is causing what injury? This hand presentation is causing the hyperabduction. So this is causing the hyperabduction of the arm. If it is hyperabducted arm, it is causing the lower trunk injury, right? So it is producing what? The lower trunk injury, and then it produces what? The Klumpke's palsy, right? Similarly, another presentation we can see over here. This is our forceps delivery. What is this one? This is the forceps. Let's say the forceps delivery. By the forceps delivery, there will be the hyperextended neck. So if the neck is hyperextended, as we said over here, it causes the upper trunk injury, right? So upper trunk injury. If the upper trunk is injured, then what happens? It produces the Ops palsy, right? So this is the another cause. So please remember this. These are the question, right? This is our question. Here is the question. Okay, so every point they make a question over here. They will explain you a person is hanging over a tree. Yes or no? So if the person is hanging over a tree, yes, so which of the following brachial plexus injury is most common? So here, if it is hanging over a tree, it produces what? Hyperabduction of the arm. So it is producing what? The lower trunk injury. That means the Klumpke's palsy. And they will say a baby has the what is this one? Breech presentation, and the presented part is the hand. And during this delivery, what is the common injury? That is what? Our again lower trunk, right? So we should understand like this. And here they will ask you somebody fall over his hyperextended neck, or they will say during the forceps delivery, what is the most common injury of the brachial plexus, right? So you can say this is our what? The upper trunk, and produces the Ops palsy. This is the etiology. Another etiology is the Burner and Stingers. What is Burner and Stingers? That means the collision during the play. Collision during play. That means two players, they may collide each other. See here collision, here collision. This is the collision forces, right? So when they collide over here, you can see the neck is extended, right? If the neck is extended like this, they most commonly injure the C5 and C6 root values, right? And this injury is not the severe injury. They just produces that tingling sensation for a while, and then player can back to play. So this injury is called what? Burner and Stinger. So again, Burner and Stinger, what is the most common injury? That is C5 and C6. Another one, Parsonage-Turner syndrome. Parsonage-Turner syndrome has different causes. So these causes can be maybe hereditary cause that affect the peripheral nervous system. Another may be the infectious cause. Another may be the lymph node swelling. What is this one? Lymph node swelling, and that compress the nerve, right? So brachial plexus. So any of these, they can compress the brachial plexus. If they compress the brachial plexus, they produces the sudden onset of shoulder pain. And if they produce a sudden onset of shoulder pain, it will begin to recover by 1 month and goes up to 18 months, right? So, or some may remain permanent as well. It begins with the pain, and then finally it may leads to the paralysis as well. Okay, and in this condition, the most common involvement is the long thoracic nerve. Most common involvement is the what? The long thoracic nerve. That is what? C5 to C7 root values. This is also our question. Okay, this is also our question, so please remember. And for this Parsonage-Turner syndrome, they have given some synonyms of the Parsonage-Turner syndrome. They may ask you in the exam sometimes with a different name, like if it involves the long thoracic nerve, it produces the scapula winging. This is a synonym, right? Another name they give like the neuralgic amyotrophy. That is neuralgic amyotrophy. And another name they give like the acute brachial neuropathy. The another name they have given as the idiopathic brachial plexus neuropathy. Right? So it has a different name. So these are the causes of the brachial plexus injury. Okay, so we are just discussing about the brachial plexus injury, that is the supraclavicular injury. Now in the supraclavicular injury, just we discussed, in the supraclavicular injuries we have the roots and then the trunks injury. Yes or no? In this root, we divide this into the pre-ganglionic or post-ganglionic, right? So this one we just discussed. So pre-ganglionic injuries, let's discuss now. In this pre-ganglionic injuries, we will discuss this pre-ganglionic injury. So this is where this is proximal or above the DRG, right? So hope you understand. Yes, dorsal root ganglion, proximal to or above the dorsal root ganglion. Where was the dorsal root ganglion? We have discussed over here, or let me make one picture for this one, right? So we have the spinal cord like this. It was like this, and we had the spinal cord this way going like this. Yes, this was the spinal cord, and from the spinal cord we had the dorsal root going like this, ventral root was going like this. Here was our dorsal root ganglia. Yes or no? Right? So and then they will combining together going like this, and they are forming this one: white ramus, gray ramus, dorsal ramus, the ventral ramus, gray ramus, white ramus, and this was our what? Dorsal root ganglion. So we are discussing about the preganglionic lesion. That means the lesion is over here before the ganglion. Okay, so if we say the lesion is before the ganglion, that is what called we as the preganglionic lesion, right? So that means proximal to or above, right? And what's the mechanism of this injury? Usually this is the avulsion of root from the spinal cord. Avulsion means they just split out from the spinal cord, so that's what is called as a avulsion. And if there is the preganglionic brachial plexus injury, it has certain presentations. So what are the presentations of the preganglionic injury? First one is the Horner syndrome. What is the Horner syndrome? Horner syndrome has some formulas to remember as SAMPLE. Okay, so let's see. S means the preganglionic injury which involves the sympathetic ganglion. It involves the sympathetic ganglion or the nerves going to the sympathetic ganglion, right? Another A for anhidrosis. Anhidrosis means, look at here, we have the sympathetic ganglion, and from here the nerve is going to the sweat gland. So if this nerve is damaged here, sweat gland does not work, so the sweating will be less. Sweating less means N, less sweating, hydrosis, N, less hydrosis, sweating. Okay, that means the sweating is less on the affected side of the face, not the everywhere. Okay, so this is anhidrosis. So what is anhidrosis? Anhidrosis means decrease sweating. And M means it produces the meiosis. MIOSIS. Meiosis means constricted pupil. That means pupil becomes constricted, right? So why the pupil is constricted? We have a reason here. See, it is going to our pupillodilator muscle. Pupillodilator. So this pupillodilator should dilate the pupil when we see in the light, right? But the pupil does not dilate when we see in the light. So that is called what? The meiosis, the constricted pupil. So it produces the constricted pupil, that is meiosis. M. And then let's go to the P. P for ptosis. PTOSIS. Ptosis means drop of eyelid. Ptosis means drop of eyelid. Why? Look at here. This is the sympathetic nerve. This is going to this is my eyelid. Eyelid has a tarsal muscle. This is also called the Mueller muscle. What do we call this one? Mueller muscle. So when this is going to the Mueller muscle, this Mueller muscle when contract, the eye opens, right? So if this nerve is paralyzed, now it cannot contract the Mueller muscle or the tarsal muscle, so that my eyelid, upper eyelid will be dropped down, covering my half of the eye, right? So that's what we call as a ptosis, or the drop eyelid. After that, next we have the L. This L means loss of ciliospinal reflex. That means what? Loss of ciliospinal reflex, or we can say simply loss of ciliary reflex, right? Ciliary reflex means what? For example, in this condition, what happens? See, so this nerve is supplying to our ciliary body as well. What is the role of the ciliary body? For example, if we see the close object, right? So if we see the close object or we see the far object, when we see the close object, our pupil should be small. When you see the far object, our pupil should be big, right? So this the changing in the shape of the pupil, it is actually because of the change in the shape of the lens. So this change in the shape of the lens according to the the distance of the object, that is called the accommodation. What is this one called? Accommodation of the eye. So if we have the ciliary ganglion, this is the, what is this one? The sympathetic ganglion involved. This accommodation of the eye is lost. So if this accommodation is lost, this is called loss of ciliospinal reflex. Okay, because the ciliary body in the eye, we have ciliary body here and ciliary body here, which controls the shape of the lens. Okay, so this is lost, so if this is lost, then what happens? The ciliary reflex or the accommodation of the eye is lost, that is L. And E means enophthalmos. Enophthalmos means our eye, the eyelid is half, eyelid is covering our eyeball half, because the eyelid is dropped. Eyelid is dropped. So if the eyelid is dropped, then what happens? The eye looks inside. So that means we can say shrunken eye or enophthalmos. Eye looks deeper inside in the orbital cavity, right? So these are the first presentation of our preganglionic injury, that is called what? The Horner's syndrome. So what is Horner's syndrome? Do we understand, right? So now let's go forward. The another presentation is the medial winging of the scapula. Medial winging of the scapula means if our preganglionic injury, it involves the long thoracic nerve with the root value of C5 to C7, right? So it paralyzes our serratus anterior muscle. So if my serratus anterior muscle is involved, if it is paralyzed, look at here, this here we have the serratus anterior muscle, and this is my long thoracic nerve, right? So if it is injured, then what happens? See, when we request the patient to push against the wall, so how is the patient presenting? Patient is pushing against the wall. So you can see the medial border of the scapula. The medial border of the scapula is projecting backward. Medial border of scapula is projecting backward medially. That's why we call this as what? The medial winging of the scapula. So this is the another presentation. Similarly, sometimes patient may have the lateral winging of the scapula. Lateral winging of the scapula means when the preganglionic injury involves the dorsal scapular nerve with the root value of C5, it may paralyze the rhomboidus muscle. Right? So if it involves the rhomboidus muscle, then see, rhomboidus muscle is pulling the scapula medially. So if this is injured, the nerve is injured, this muscle does not work. If this muscle does not work, then our scapula will be pushed laterally. See, they cannot pull it medially, so that we can see scapula going away from the midline. Our midline is over here, scapula is going far away from the midline. It should be the normal medial border of the scapula, but it is shifting laterally. That is what we call as the lateral winging of the scapula, right? So one point I want you to remember here, the lateral winging of the scapula involves two nerves. One is the dorsal scapular nerve, another one is the spinal accessory nerve. If the dorsal scapular nerve is involved, it is the rhomboidus muscle. If this what is this one? This spinal accessory nerve is involved, it is the trapezius muscle, right? So this can also cause the lateral winging, this can also cause the lateral winging of the scapula. So please remember these two. So these are the questions in the exam. So remember, these all are the questions in the exam, the nerve, the root values as well. Okay, so we can see here, this is my medial winging of the scapula, and here I have the lateral winging of the scapula. So see the distance here, and then see the distance over here. Okay, and another one, it produces the flail arm. The presentation is what? Flail arm. The flail arm means what? The the long term wasting of the muscles, the muscles of upper limb. That means if the nerve is injured, then finally what happens? The nerve going to these muscles, they are damaged, so these muscles becomes non-functional. If they become non-functional after the long period of time, they become weaker. These muscles, when the muscles become weaker, they undergoes atrophy, and then the size becomes smaller. So that's what we call as the flail arm, right? So another presentation is that the absence of the tinal sign. Tinal sign means, remember, the tingling sensation. What is this one? Tingling sensation on tapping is called the tinal sign. So that sometimes we can check the tinal sign by, look at here, we are tapping over the neck over here. While tapping this, the tingling sensation is absent. That means the nerve, they are not functioning well. So that means what? This is called the absence of the Tinel sign. Similarly, it will show the normal histamine test. Normal histamine test means we inject some amount of the histamine. What do we do? Histamine injection in the skin. Where do we inject? In the skin of the upper limb, right? So when we inject the histamine, a little amount of histamine over the skin of the upper limb, it produces three changes. The changes you can see here. Here you can see the white line over here in the middle, right? So like this, you can see the white line here, yes or no? So this line is called the wale. See, it's swelling in the middle, and this swelling, around the swelling you can see the redness, right? So around this redness is increasing to the side. So this swelling is called the wale. This redness is called the erythema, and then when it is expanding, this is called the flare. But in this picture, look at here, you can see the wale in the middle. You can see a small erythema, but this erythema is not expanding by the side, so it has no flare, right? So that means in this picture you can see positive histamine test. That means it produces three things here: wale, erythema, and then what is this one? It is going out, that means flare. So if these three things present, that is, this test is positive. If, look at here only the flare present, sorry, not the flare, the wale is present, erythema is present, but flare is absent. So this is called the negative histamine test, right? So that we can see here, in case of the preganglionic injury, it causes the normal histamine test. That means it produces the wale, it also produces the erythema. Erythema means redness, plus it produces the flare. Flare means expanding, so like this one, okay? So it is normal in case of preganglionic injury. Plus it produces the elevated hemidiaphragm. Elevated hemidiaphragm means it involves the root value C5 plus C4 plus C3. This is not the brachial plexus, right? So if it involves C5, this is for the phrenic nerve. This is for what? Phrenic nerve. Phrenic nerve root value is C5, C4, C3. So C5 is a brachial plexus. So if preganglionic C5 is injured, the phrenic nerve does not work. So that what happens? Look at here, the normal diaphragm is in this level. So this is the normal level, both side diaphragm. Both side diaphragm, look at here, this dome is of diaphragm, okay? So if this diaphragm is in the same level, that is the normal diaphragm. But in this picture, look at here, one diaphragm is here, another diaphragm is here. That means this side, the phrenic nerve is not working. That's why this side diaphragm cannot contract during the respiration, inspiration or expiration. That's why it goes up. Is that okay? So this is called the hemidiaphragm, right? So these are the symptoms of our what? The presentations of our preganglionic brachial plexus injury. So what are the presentations? Number one, we said Hodner syndrome. Number two, we said medial winging of the scapula. Number three, we said the lateral winging of the scapula. And then the number four, we say the flail arm. Similarly, the Tinel sign is the absent. And we say the normal histamine test, plus we say the elevated hemidiaphragm, right? One side of the diaphragm is going up because of the phrenic nerve involvement, right? So this is the preganglionic nerve injury. That means this involves the C and S involved, right? So if it involves the C and S, the regeneration of the nerve is poor. If the regeneration is poor, then the prognosis is very poor, right? So because of the involvement of what? C and S, that is the prognosis. And for the the preganglionic or postganglionic nerve involvement, we can do the muscle test. So what are those muscles we can test for? So these muscles are, we can test for the what is this one? Serratus anterior muscle, like the medial winging. Similarly, the rhomboidus major or minor muscle, right? So this is for the lateral winging, we can check. Medial winging, this is lateral winging, we can check. And another muscle we said was we didn't say before, but here we can do the EMG, electromyography. This electromyography of the spinalis muscle, or we can say the we can say paraspinalis muscle. Paraspinalis muscle, right? So this, the paraspinalis muscle, we have three different types of paraspinalis muscles: in the lumbar region, the thoracic region, and then the lumbar region, thoracic region, and then the cervical region. We have three three paraspinalis muscle. Okay, so these paraspinalis muscles in the three regions, they are named as you can see here. We have the iliocostal one, right? Iliocostal in three different regions. Similarly, we have the longissimus over here, right? And then we can see here the spinalis over here, right? So these spinalis, longissimus, and iliocostalis. You can see iliocostalis is most laterally, yes, longissimus is in the middle, and then the spinalis is most medially. This is also the question in the exam. So these are also the questions they will ask you in the exam, right? The most lateral, middle, and medial. So which of the following paraspinalis muscles, they are this is the most lateral, this is the middle, and this is the medial. Okay, so they will ask you the question like this. So we can see here iliocostalis is most lateral, and then we have here longissimus, right? So longissimus is in the middle, and then the spinalis is most medial, right? So this, remember this for the exam. And this is not related to the brachial plexus, but if you see this one, the what is this one? Iliocostalis, you have the longissimus, and then the spinalis, right? So we can check the EMG, electromyography, of the cervical paraspinalis muscle, right? So all of these muscles function is lost in case of preganglionic injury, right? If it is post-ganglionic injury, all of these muscles are intact in their functions. Okay, so now let's go to the post-ganglionic injury. In the post-ganglionic injury, now we know already what is post-ganglionic injury. This is our spinal cord, right? So if this is our spinal cord, right, like this, in this we already discussed, this is my dorsal root ganglia, yes or no? So this is my dorsal root ganglia. We just discussed was the pre-ganglionic injury. Now we are discussing about the post-ganglionic injury, that is post-ganglionic injury. This is my pre-ganglionic injury. Okay, so let's talk about the post-ganglionic injury. First point, the location we have to understand. What is the location? Location is, that is below or distal to dorsal root ganglion. That is the location of the post-ganglionic injury. And what are the presentations of the post-ganglionic injuries? The presentations of the post-ganglionic injuries are, first point, you can see the flail arm at same like that of the same as pre-ganglionic injury. We don't have to discuss much. And second, you will see the histamine test, that will be abnormal. Okay, that will be abnormal. Abnormal means what? Abnormal means you will see the you will see the erythema, they are positive, but the flare, as like we discussed in the preganglionic, flare is negative, right? So this is the negative histamine test. Okay, that is abnormal. And we can do the EMG. In the EMG, we can do the cervical paraspinalis, just to discuss cervical paraspinalis, that is the iliocostal, the longissimus, and then the spinalis muscles, right? So we can do this one. This comes normal. Similarly, you can check for the serratus anterior muscle. Similarly, you can check for the rhomboidus major and minor muscle, right? So these will be also intact. Then this is called what? The post-ganglionic brachial plexus injury. That means it is involving what? It is involving the root of the brachial plexus. So do we understand about the preganglionic and post-ganglionic nerve injuries? We also know about the what is this one? The trunk injuries as well, right? So this is our what? Ops palsy, and this is our Klumpke's palsy. But we haven't discussed about the cords and branches, yes or no? So in this cords and branches, we will discuss the detail later, but here I just want to give you one formula, that is Dr. CUMAB. So please remember this one as Dr. Kumab. Okay, so number one, let's see DR. DR means drop wrist. That is seen in the radial nerve injury. Okay, so remember this one. And then number two, we will discuss CU. What is this one? CU. CU means you have the claw. And what is this? The detail we will discuss. Claw hand, you will see in the ulnar nerve injury. And then number three, you have that number three is MAV, that is MAV. MAV means you have the median nerve. What is this one? The median nerve. This median nerve, you will see two things. One, A for app hand, and B for benediction, hand, right? So the details of this we will discuss, because we will discuss them as the three locations of the lesions, like very high lesion, low lesion. Very high lesion means lesion in the axilla, we discussed, right? High lesion means the lesion in the arm, and low lesion means lesion in the elbow and below, right? So these are the locations of the injury. So we will discuss them in details in the next lecture. So hope you understand about the brachial plexus injury, right? So if you have any questions, any queries, please follow the lecture, the stepwise, because we have the lectures part by part. And if you have any questions, you can just give me the comment. So please don't forget to like and subscribe, and share my channel. Thank you for watching. Thank you very much.